Oh, sorry. Okay, for the third time, I want to introduce Mike Cantrell. He
computer guy too. I'm a computer wizard.
So postural restoration is it's hard to describe but it's not physical therapy. Okay, when we're treating TMD, do you know that we are the only practitioners who teach the joint without collaborative work with somebody to rehabilitate? I mean, if you go and you hurt your knee, you see an orthopedics, and you get knee surgery, or you just get a brace for a sprained knee and all that, afterwards, what do you automatically know that you're gonna do? Physical therapy, right? And so, but we are the only one who treats sprained joints with no physical therapy. So how do we expect it to work? We're the only ones. Are our splints that magical? You know, I don't think so. So I think it's about time that we join the rest of the medical community in doing things in the right path where we can get whole body healing. And so James Guzman is a performance specialist. He actually has been with Postural Restoration Institute for nearly 15 years, right?
Quite a while. I've been around for a while.
Yeah, so he practices with us. He's actually here in Houston. So, you know, when I first started doing this, I was searching high and low. I was sending patients to Dallas and Austin because we had nobody. Back then, James was in a hospital system, so he couldn't really practice, you know, in a private practice like us. But I went to a course I met Mike Cantrell. He introduced me to James. We pulled James out of the hospital system, and now he's practicing with us. But I really want to welcome, what's your name? No. Mike Cantrell.
For the fourth time.
According to my kids, Mr. Mike. I want to introduce you to Mike Cantrell. He has literally just changed my life so much that I'm actually selling my restorative practice by the end of the year, and I'm going to enter this arena fully 100%, because when I see patients, there's almost never a moment where the patients look at me without tears. Today, we had someone who plays for Rice football. He's in the Army in Afghanistan for about 8 years, torn everything in his body. He has dissociative disorders because of the post-traumatic stress that he had over all of that. And he came in, Mike helped him breathe, and he spoke his language. The guy was literally a huge man. He was in tears. He said, finally, I find somebody who speaks the language that I feel and I hear, but everyone tells me is PTSD, so it's in my head. Okay, so that's the work that is available to you all. And Mike Cantrell is a master at it. It's Postural Restoration is up in Lincoln, Nebraska. I've taken probably about 8 or 9 courses from them. We speed track through several courses with Mike, one-on-one. And then, but he has been with the Postural Restoration Institute since its inception. In fact, he developed many of the methodology that the postural restoration world is working today, And so if you guys want to kind of have an idea of who he is in the postural world, postural restoration has been around almost 25 years. So we have Pete Dawson, Frank Spear, you know, John Coyce and all that. You know, John's really analytical. Frank is beautiful at making the complex simple. And then Pete speaks in the terms of theories and all that. They're all good with their own style. Well, me and Liz Cahey in Dallas, we said, this is Frank Spear of the PRI. So, but he's Mike Cantrell. He's awesome. Come on up, Mike.
So, but I did have a good opportunity to drink a lot of wine. Really
Yikes.
I'm feeling nice right now. I will say this though. So in 1996 or 97 that I walked into a course taught by a man named Ron Haruska. And Ron Haruska, he was my mentor, and that day in 1997 was actually in Houston, Texas. Go figure that. And I walked into that course. Oh, the lavalier.
I forgot.
So I walked into that course, That course changed the way I practiced physical therapy. I realized at that point that, being a physical therapist is kind of boring. And when you tell somebody on a plane you're a physical therapist, it's like, oh, well, that's nice. I have a friend who's a chiro. I'm like, cool. I mean, that's great. Or they'll say, well, what do you do? And you're like, well, I don't want to get into what I do. I mean, look where I'm standing right now. Like, what do you do? Well, I don't want to tell them that I engage with dentists and oromyofunctional therapists to improve, and then I say that word posture. And I hate that word because immediately everybody wants to sit up straight. And it's not that. If I were to encompass what I do, what I would say to that person, I mean, if they really were interested, like if they really wanted to know, I would say, so my obsession that began in 1997 helped me realize that a pronated left foot creates internal rotation of a left tibia and compensatory external rotation of a left femur with compensatory internal rotation of a right femur with compensatory left forward rotation of an innominate with external rotation, which causes elevation of my left pelvic floor. And that assessment in the bottom part of my body creates some loss of a zone of apposition on the left side of a rib cage and causes rib cage, I'm going to say the word pronation, on the left side in the anterior portion, which causes a diaphragm to lose its zone of apposition. And that loss of a zone of apposition on the left diaphragm is the resultant compensatory leftward rotation of my thorax because of my human asymmetry that is born from a right brain and a left brain that are two different animals that never communicate well through the corpus callosum. The end result of that loss of communication through the corpus callosum is this external rotation of a left set of ribs and an internal rotation of a left set of right ribs. So consequently, that resultant position causes internal rotation of my right scapula and external rotation of the left scapula in the vertical axis. And in the sagittal axis, it would cause forward rotation of the right and backward rotation of the left. All at the same time, it results in a right thoracolumbar convexity scoliosis that could be compensatory and create a left lumbar convexity scoliosis, but we won't get into that. But meanwhile, further up in the head, what you see is left mid-cervical lateral flexion, a right shoulder that's lower than left, like you mentioned a while ago, left cervical axial rotation, posterior rotation of a right temporal bone because the occiput is turning to the left on the axis, which is rotating to the right, anterior rotation of the left temporal bone, and at the same time, migration of, of two mandibular condyles that are chasing a fossa, like you mentioned a while ago. That's kind of what I do. Right? So usually the patient is hanging themselves, or the person I'm talking to is suspended now from a rope by the neck, or chewing their last cyanide tablet, or frantically clicking their pistol, begging somebody to end their life for them as Mike continues to talk. What I want to talk about today, though, is this, and it's so much easier because, when the folks were up here a while ago showing that facial asymmetry, that is my obsession. So, I'm back there having a nerdgasm as they're putting this up on the screen. And I'm obsessing over what I see because that's my world. I know that that lady's face had an internally rotated left palate because that's my world. I would know that she has a pronated left foot. I know that her center of mass is forward on the balls of her feet, which is what we're going to obsess on tonight. I know this. He knows this. She knows this. Because we spend a lot of time nerding out on it. So it's my little...
The class I took from him, they spent 4 hours on looking at feet and occlusion teeth. So you got all this attractive and feet. That's all we did the entire
It's
hour.
really pathetic.
You start seeing
It's amazing.
So this has become my little world.
with your teeth and you eat with your feet.
Fact.
Fact.
So if you can embrace first, and you don't have to embrace this concept, the research abounds on this material. It's in journal after journal after journal after journal. The problem is, here's a podiatrist publishing information about what feet can do to faces. Here's a neurologist saying something called Yakovlevian torque exists within the brain such that the brain is scoliotic. Here's someone in the Netherlands named Kuvenhoven who says that all God's children have a scoliotic curve to the right, unless they don't, and then it's compensatory. So there's different wells, different silos of people that are saying the same thing in their journals. And it took a mentor for me to back up and look and go, wow, they're all saying the same thing, just in their language. The coolest thing about Houston, Texas is rooms like this. Because for me, you know what it's like to sit and speak with a perpetual goosebump? Because I have one right now. Because the obsession in this room is collaboration. And it almost makes my eyes water. Truly. That's why I'm so grateful for what I see happening here. If you would have told me in 1997 when I wandered into that class to just learn about this sort of a brace that pulls pelvises back, that I would be where I'm standing right now in front of what I consider to be the black belts of their craft, I would tell you, you're full of beans. There's no way. But at some point in your journey, because each one of y'all are in your own journey learning your material at your obsessive compulsive rate. And so it's like at some point, you know, you want to go, Mike, give me that clicker. Let me tell you about what I do. The last time I was in this room, John Karotkin was talking. And I was so obsessed with what he was talking about. And then I was like, give me the clicker. I want to talk too. Because I wanted to share this information that I have. So what I will tell you right now regarding this is easy. Because what I wanted to not do was what I always do. And that's talk about human asymmetry. Because human asymmetry is the problem. And the last time I talked was in a restaurant here, and I got to have a glass of wine or two there too. And I didn't ever get to eat though. That was a real problem for me. But I did get to eat here. Anyway, I spoke about human asymmetry and just kind of gave an overview of my obsession with it. And that human asymmetry matters. The left half of me is not like the right half. Nobody walks in with perfect CR. And I want to redefine CR. Because CR, as it's defined by Pete Dawson, my mentor, is not what I would consider to be accurate. Because CR is respiration driven. There, I said it. So this respiratory drive for centric relation affects the position of these two fascias. And if I'm on my right leg versus my left leg, if I assume a posture of right stance, this is a different posture than left stance. It's not sit up straight. In fact, I'd rather you slouch. But this posture of right stance affects the position of these two fascias. Forget the condyle. This is easy math. This is 2 + 2. This is calculus. And I want to know calculus. And I suck at math, just for the record. Now, I said this is easy because what I want to do is leave all of that out for the moment. We can get obsessive compulsive about human asymmetry, and I can throw a little in here and there as we're discussing this. But this I think you'll kind of groove on. So this class, let me see how my clicker's working here. Yeah, all right, so this seems to be working. Oh. The views and thoughts and opinions expressed in this only belong to the author, is influenced by the author's 32 years of clinical experience and come from multiple sources, which I will cite. The content is not intended to be a comprehensive treatise on this topic, because I guarantee you if I handed this clicker to Christy Gatto, she could say, oh yeah, let me tell you. And she could add to this. She could go over there and click into my slide presentation and add material that I don't know a damn thing about. That's why I'm so grateful to be in the room. Because I know I'm standing among giants. I'm humbled to be standing in front of you right now. I promise you that. I think you have an idea. I was about to say you have no idea, but I think you have an idea. I have mentors. Ron Haruska was the guy who taught me that day in 1997. The Posture Restoration Institute, for whom I taught for 20 years and wrote much of their literature, is a mentor for me. James Anderson, my partner, is a mentor for me. Julie Blandon, with whom I've worked for many years, is a mentor for me. Elizabeth Cahey, the dentist that introduced me to Alice Lamb, with whom I work now, and I've worked with her for 8 years now, is a mentor for me. I cheat off her paper all the time. The Pankey Institute and Dr. Derek Nordstrom, who developed a device called an ALF. In addition, the Alpha Interface Academy, and there he is, Pete Dawson. I had a chance to speak with him after his last keynote address, and he came down off the stage after delivering an address speaking about the concept of centric relation. And he said there was a lot of blood on the walls over the last 30 years as we hardened our definition of centric relation. And I think we finally got it, was the gist of his 1-hour speech. He came off the stage, and I went up to him and I said, Dr. Dawson, my name's Mike Cantrell, I'm glad to meet you. And he said, oh, I'm glad to meet you too. I said, yeah, I'm a physical therapist. He said, oh yeah, we have a physical therapist here today. And I was like, yeah, I think I'm the only other one. There was like 3,000 people at the AES, the American Equilibration Society. So I said, yeah, I mean, I'm the other schmuck. And I said, but I think we need to change the definition of centric relation. Y'all, he looked at me like I had lobsters coming out of my face. And he goes, who are you? And I said, Mike Cantrell. You know, and now I'm getting a little shaky. And so I said, well, yeah, but I think we need to change the definition of this concept of centric relation because you're not basing it on airway. And you can't have a decent discussion about centric relation without airway discussion. And he said, do you know Mariano Roccabato? And I said, yes, sir, I've taken some of his classes. Well, I work with Mariano Roccabato. And I said, yeah, he's cool. He's got a lot of great orthopedic concepts, but I'm speaking neurology now. So this is 2020 or 2019, I guess is when it was, 2018 maybe, whenever that talk was. So I said, yeah, I want to meet with you. So he gave me a card and he said, I want you to call me. So I was like, cool, he's interested. So as I left and we chatted about that, Alice is like, you really just did that? And I was like, yeah, I'm dumb. And then he passed away. So we never had the opportunity to have that conversation. But I'm still kicking, and I've heard dying is in vogue, and I've decided I'll do it at some point, but right now I'm not going to do it. So in the meantime, what I'm going to do is keep nerding out on this stuff and redefine this centric relation. That is my current obsession. So we're going to get to that. The Dawson Academy and Alice, because I've cheated off her paper a whole lot. She's just not aware of it, but I have been. When she's not looking, I'm cheating. Yeah, she's aware now. So there's a ton of studies that demonstrate a relationship between body posture, breathing, the neck, mandibular mechanics, tongue position, and TMJ dysfunction. I promise I'm not going to read to you the whole time. But I do want you to see a few of these studies, because one thing I want you to understand is where they're coming from. Neuroscience Letters is speaking about mood states and anxiety influence abilities to maintain balance control in healthy human subjects. Gangloff talks about dental occlusion modifies gaze and posture stabilization in human subjects. Now, I also work with Dr. Heidi Wise. Heidi Wise has developed something called postural vision, and through the Posture Restoration Institute, and she worked with PRI for many, many years and developed PRI vision. She's moved to Georgia since, so now I get to cheat off her paper too. What if I said vision affects airway? There's a concept. So just kind of, put that egg under you and hatch it for a while, because we are going to be talking at some point about that. So there is a place at AAPMD for optometrists. There's a huge place. When you have an ALF in someone's mouth, is Angela in here? Oh yeah. So when you have an ALF in someone's mouth and you modify vision and the ALF falls out of their mouth, did we just create palatal expansion with vision? The answer is yes, because we created cranial expansion. But I'll get to that later. So malocclusion, body posture, and TM disorder in children with primary mixed dentition. Look where the research articles are coming from. European Journal of Orthodontics, Neuroscience Letters. Let's keep going. Fujimoto says, changes in gait stability are induced by alteration of mandibular position. Look where these articles are coming from. We're all in our own wells. Scandinavian Journal of Dentistry. Lund says, postural activity in muscles of mastication with subjects in upright, incline, and supine. Take-home message is it changes. Sforza said, occlusion, sternocleidomastoid muscle activity, and body sway, a pilot study in male astronauts. In Cranio. Lippold says, there's a relationship between thoracic, lordotic, and pelvic inclination and craniofacial morphology in adults. In Angle Orthodontics, this is a big deal. Haruska, my mentor, spoke of the influences of dysfunctional respiratory mechanics on orofacial pain back when Christ was a corporal. He was doing this before it was cool. And he's speaking a language that nobody understood. Airway's not related to airway and tongues. It is. It's related to where your feet are hitting the ground. It's like, okay, that's a little whacked for me. That's a little far out. Can we back it up just a little bit? I need to know this better. These go on and on. This is just a sampling of 1,500 articles that I've obsessed on because I'm a nerd. I wish I wasn't. So if we explore the research, and I'm not going to read to you the whole time, I promise you, coupled with clinical cases, it reveals a causation for bruxism and low-lying tongue posture. This causation appears not to have been deeply explored, but can easily correlate with existing postulates regarding airway dysfunction and bruxism and tongue posture. So this little presentation is to examine and gain a better understanding of positional airway compromise emanating from this area down, from here down. I'm going to talk a little bit about here, but I want to obsess about here. So let's get there as quickly as we can. We'll have more fun. So top-down stuff we know about, tongue restrictions, like this kind of jazz. You guys see that all day long. This is old news. My grandmother knows about this. Posterior tongue ties, you know about that. Bruxism and grinding, we're going to discuss that as a bottom-up phenomena. So medications that tend to cause people to brux, I don't know if this may be new news for somebody, but if it's old news, fine. But there are certain meds that can cause people to clench their teeth. So there they are. We also know that malocclusions can result in bruxism and paradoxical activity, but not always. It's because the implication there is, oh, well then normal occlusion doesn't. But what I can tell you is that reinforced normal occlusion on a badly positioned body reinforces bad position for the body. In other words, my teeth are massive proprioceptors that define where I am in space. This is why people who are missing lots of teeth fall down a lot. It's not because they're old. It's because they're old and they don't have proprioception. So if we understand that thought, that proprioceptive awareness can emanate from 20,000 nerve endings per square, what is it, millimeter? Centimeter? A tiny space. I think it's millimeter. That's a lot of sensory input. You know, let me state something that's common sense. If there's a hair between my toes, I don't mind. But if there's a hair between my teeth, I go crazy. Just saying. That's kind of common sense, isn't it? I like to keep the complex simple. So this is kind of cool, this prime scan thing. So Dentsply, weren't they here tonight? I want you to check this out because this is kind of neat. So what I want you to see as you're looking at this 3D scan, we're looking at the roof of a mouth, and I'm going to kind of pause it right there. What I want you to see is I know for a fact that this person is pronating on their left foot. Because what he has is an internally rotated left palate versus an externally rotated right palate. Is that like a tune? It added drama to this talk, didn't it? I was kind of grooving on that. Can we do that again? So this internally rotated left palate and externally rotated right palate tells me that this individual is spending most of their time oriented into their right hemisphere of movement. I see a human in right stance. But there's evidence of that that is objective, that we can put someone on a table and assess easily in their legs, in their pelvis, in their rib cage, in their neck, in their head, in their bite. And this is just one little shred of evidence, crystal clear shred of evidence. This is pretty damn cool. So yeah, we might be, if I'm a dentist, I might be looking at the teeth in that. I don't know what you guys look at. But as a physical therapist, I'm OCDing about that palate. And I'm OCDing about what that human is doing to create that palate. That's what I'm kind of grooving on. I know that it might be hard for that tongue to spend much time in that left roof of the mouth. I know that this person may not spend much time on that incisive papillae, which, by the way, is a parasympathetic hormone releaser.
Yeah, so next time you guys take an algae impression, look at the impression from the back. It's going to like just totally give you a different perspective. You can actually just look at that and know what's going on with the tongue.
This position would be defined by an osteopath with whom I spend a lot of time chatting as a left cranial side bend strain pattern, which creates anterior rotation of a left temporal bone and posterior rotation of a right, which happens to coincide with pelvis position. But I swore I wasn't going to go into asymmetry. So let's kind of keep it simple, stupid, right? The KISS rule. So we're going to keep it simple. So I'm going to press. Let's keep going here. See if I can get my clicker to behave. Maybe it's just because it's a video. Let's try it this way. Now, let's try. Yeah. So, upper stuff can be also nasopharyngeal. There are issues within the nasal cavity like deviated septums, etc., that can cause restrictions in airflow. We all know this. This is old news. We also know that if there is some narrowness of the airway here, it can be from tonsils or from adenoids that are larger than they ought to be. I'm preaching to the choir, right? So this is old news. Now let's now that I've burned through this top-down stuff that is old hat, let's go from bottom up, shall we? Let's do that. So top-down problems with respiration are legitimate concerns that can be quite evident when the patient is closely observed, but there's a bottom-up consideration. So I want to talk about the mechanics of respiration for a moment. So, kind of fun. I spend a lot of time in the baseball world. And I'm from Atlanta. I just thought I'd get that out now. So technically, I'm from South Georgia. I'm about 100 miles south of Atlanta. And so I live in the middle of nowhere on a farm. And I have 35 acres of pecans, and I like to hunt deer, and I fish whenever I can. And I just do this to support that habit. Just full disclosure, okay? There's a reason why I'm a nerd. But I do spend a lot of time. It's funny who's obsessed with this material that we like. So Major League Baseball is obsessed with this stuff. So I've spent a lot of time teaching Major League Baseball players how to blow up balloons. So I spent a lot of time in the golf world teaching golfers how to blow up balloons. So I don't know if you're familiar with Jason Day, but I spend some time with him, and my partner James does as well. And we get to make him blow up balloons, and he's like, what the hell is this? We're like, shut up and blow. But anyway, so we're using this balloon as sort of an oral reference for tongue position during the pause, during the inhale, during the exhale, and we can get into that on another day. My point of telling you all this is not to tell you I'm some big shot who works with these fancy people. What I'm telling you is there is an obsession in different places. I spend some time working with Navy SEALs. The funny part about the Navy SEALs is they're like, okay, we're going to bring you out again. We need you to work with us again, but you can't tell anybody. I'm like, can I tell people? And they say, you can tell people, but you can't write it down. I'm like, because it's a big secret. And they're like, well, yeah. I'm like, you realize this is not a secret. Everybody knows. It's so dumb. But they like to think everything's a secret. This is classified. I'm like, it's not classified. They're like, well, it ought to be. I'm like, you guys are killing me. So let's talk about this respiration thing. Normal, quiet inhalation is carried out through activation of the diaphragm, the external intercostals. Normal, quiet exhalation is a passive activity that requires no muscle activation, but is more dependent upon elastic recoil for expiration. Now, Detroyer speaks to this a great deal in Functional Anatomy of Respiratory Muscles in Clin Chest Med, and Soley speaks in the Etiology of Effort Syndrome in the American Journal of Medical Science. Both of these articles and many more speak to the concept of normal, quiet respiration. You're doing it now. Half of the room, actually 2/3 of the room, if you were to pause and think about it, are sitting more on your right butt bone than your left as you do it, which is kind of an interesting concept. And the room just swayed. So that concept of normal, quiet respiration being a more of a belly activity, we all get that. We've heard that, right? Normal breathing, you should see belly breathing. And in fact, in yoga, they teach belly breathe. And there's names for that in yoga speak. I don't know those names, but there's names for that. But what I'm going to tell you is people are the black belts of belly breathing. In fact, they're too damn good at it. They can't apically expand. They can't laterally expand. They certainly can't expand their posterior mediastinum, and they cannot expand one side as well as the other, if I get into that asymmetry thing again. So normal quiet respiration is easy, at least for some people. But for others, it's not so easy. Let's continue. Respiratory activity is continuously challenged on a day-to-day basis, and they can affect muscle activity. Something as simple as watching an exciting movie can cause respiratory rates to increase and then alter normal recruitment of respiratory muscles. This is actually a pretty good example that I found. So this guy and the gal, I would say both of them have altered body position to improve airflow. I mean, it's kind of bloody simple, right? So we all do this, by the way, not just when we're watching a scary movie, but we all do this. We alter body position and assume the path of least resistance for airflow. We all do it. That's why most of the room was on their right sit bone, because it's just easier to fill the left chest than it is the right, because we're asymmetric humans. So if you only did it once, it would never be a problem. He'll get over that. But if you're doing it for 45 years or 5 years, it now might become a problem. You know, Mom was right. If you make that face long enough, son, it's going to stick like that. Challenges to normal respiratory activity can be even more intense as a result of high-level physical activity or even pathologic in the form of unrelenting, heightened sympathetic drive stemming from moderate to severe psychological disorders such as panic attacks and similar. Tons of the patients that we treat are on Xanax or some other medication to help them not have panic attacks. All of them are suffering from something called chronic hyperventilation syndrome or chronic hyperinflation syndrome. So if everybody in here, let's have an example of chronic hyperinflation syndrome. Everybody take a giant breath in. Hold your breath. Now, listen carefully. Go ahead and inhale. Oh, well, wait a minute, Mike. I have a bolus of air in my lungs now. You just said inhale. I think you meant exhale. No, I meant inhale. That is an example, you can relax, of chronic hyperinflation syndrome. People who are in a heightened state of anxiety inflate, place a bolus of air in their lungs, and continue to breathe on top of that bolus of air. That dog won't hunt. You can't do that for long. If we were all standing up, this is what you would look like if I said do that. Watch me. I'm going to take a giant breath of air in. My center of mass went forward. I feel pressure on the balls of my feet now. As a result, I feel increased low back muscle activity. As I'm falling forward, I'm holding myself up with my low back. Do any of your patients have low back pain? I'm just wondering, like everybody in here, right? So could it possibly be that this hyper erect, gosh, Mike has good posture. Yeah, this would kick my ass if I stood here long enough. No one can maintain good posture is bad. There, I said it. Let's just get it out on the table. Good posture is bad. I'm begging you to slouch. You heard it from the physical therapist. I'm begging you. Let's continue. So I can increase my rate of respiration to manage my dyspnea. So define dyspnea. Dyspnea is the awareness that I'm having a difficult time breathing. Now I need to manage that. Gosh, I'm having a hard time breathing. I think I'll manage that by, increasing my rate of respiration. Okay, that helped. Now I've got it. I'm under control. Let's go running together. Anybody a really good runner in here? Decent runner? Half-assed runner? Okay. So Laura and I are going to take off on a run. Now, of course, I'd kick her ass running because I can run. No, I can't. I run to not fat ass. So she runs because she enjoys the activity. I hate to run, but we decided to take off and go run together. Now, there's no way I'm going to be able to keep up with her. So I have options, right? I can struggle to keep up with her and increase my rate of respiration because I am now becoming dyspneic. Is that a word? I am now dyspneic. She's trotting along just fine. Like, what's your problem, Cantrell? So I have to step up my rate of respiration in order to keep up with her. Or I could slow down to manage my dyspnea and not keep up with her. Does this make sense? So athletic activity will increase my rate of respiration. That makes perfect sense. I could also be panicking and increasing my rate of respiration to take care of that. Why is he breathing into the bag? You gotta love Sheldon. So why is Sheldon breathing into the bag? Let's think about O2 and CO2 balance and acid-base balance for a moment. O2, CO2. If I increase my rate, first of all, let's talk about this balance. If my O2 is elevated, my body says, no problem, bronchioles, go ahead and constrict. Blood vessels, go ahead and constrict. We've got enough O2. If my O2 is depressed, my brain says, bronchioles, dilate, we need more air. Blood vessels, dilate, we need more oxygen. Makes sense, right? What if I hyperventilate? I'm blowing off CO2 in a desperate attempt to get more air. Am I successful? Oh, hell no. Because what's happening now, because I see O2 going up, bronchioles constrict. Panic attack. So what I would need to learn to do is maybe breathe out and pause and build my CO2 back up. Konstantin Buteyko wrote a lot of material about that. He was a Russian pulmonologist who spoke to this subject. So if I understand that little concept, we know why he's rebreathing his CO2, to get his bronchioles and blood vessels to dilate. The whole point of this slide is to understand two things. There are two ways that I can manage this issue, right? I can have normal respiratory activity that can be challenged by high-level physical activity or from unrelenting, heightened sympathetic drive. This is fine. And I can go run. But this is intolerable by our patients. And it is an etiology for a low-lying tongue. Let's continue. We're rocking, yeah, baby. That's what I'm talking about. Rate and quality of respiration can be varied and neurologically driven. Exercise with varying intensity, anxiety with varying intensity. Additionally, positional influences on the rib cage and subsequently the diaphragm can influence the ability to adequately breathe. which results in increased respiratory rates. So let me explain. What she's doing here is placing her diaphragm in a state of extension. My diaphragm, right, left, inside me. When I inhale, my diaphragm descends. Inhale. Exhale. Ribs. Externally rotate. Internally rotate. Normal. Now, let's inhale and hold this position for a minute. Where's my center of mass? Forward on the balls of my feet. You with me? My posture, hyper erect. Look at her, and what you're seeing is she's altering her position, flattening her diaphragm into a state of extension or activity or flatness, which loses the dome. How can you inhale more if you've already inhaled? My diaphragm's already descended, Mike. Please allow me to return my diaphragm to its resting state so that I can then inhale, please. So, yeah, I'm game for that. Your patients are begging for this. Your patients are walking in saying, I've got my diaphragm in a flattened state with a loss of zone of apposition that happens to be greater on one side than the other. Could you please help me? That's what they're saying. But we have to interpret through the fog of war, of all of the stuff that they're bringing to the table. It comes out. It's like, I always tell my wife, my anniversary's this weekend, by the way. I'm proud of that. But anyway, I tell my wife all these things about how cool she is and how neat she is, and it always just comes out, I love you. Our patients are walking in saying, my back hurts. What they're really telling you is, I can't exhale. My neck hurts. What they're really saying is, I can't exhale. I clench my teeth to the point that I've sawed them down to nothing. What they're really telling you is, I can't exhale. Do you hear me saying exhale? It's like the Whitney Houston movie. You remember that, Waiting to Exhale? It's that. Scopa said there's a relationship between body posture and tongue posture. What? In Acta Medica Mediterranea. Chaitau said breathing pattern disorders and motor control and lower back pain are one and the same in the Journal of Osteopathic Medicine. Back in 2004. Where were we? Cuccia said this. All right, so we're going to read about that in a minute. Flexion or extension states of the pelvis, spine, rib cage, and diaphragm can create difficulties with normal inhalation and exhalation. There's a correlation between craniofacial parameters, in other words, mid-face development. This is Cuccia's article. Back shape profiles. Patients with distal and vertical craniofacial patterns present higher than normal upper thoracic, lumbar lordotic, and pelvic angles. Patients with mesial and horizontal craniofacial patterns present smaller than normal upper thoracic, lumbar lordotic, and pelvic angles. Boom, in your face. It's right there. Like literally in your face, like your face.
Can you translate that?
No, hell no, I'm not going to translate that. So what I really mean by that is if I pitch my pelvis forward, I flatten my mid-back and deepen my lumbar curve, which flattens my neck, which takes my atlas and moves it back on my occiput. I'm facing that way. Here's my occiput. This is my first cervical vertebra. My atlas moves back as my neck curve straightens. Do you guys ever have patients with straight necks? Frog's ass watertight? So that thing moves back. And when the atlas moves back on the occiput, we then have low-lying tongue posture. When the tongue lays low, the mid-face doesn't develop. Right? Let's continue. Because it gets better. So, not only can there be a neurologic drive for increased use of primary and accessory muscles of respiration, there can also be a postural influence, right? This is kind of what we were just talking about. And it creates a demand for increased activity. Hyperventilation of the body. This is actually a good article, Journal of Bodywork and Movement Therapies. Look when it was written. 98. Remember, I walked into that class in Houston in 97. My kids were little. My kids right now, my son is 29, my middle daughter is 27, and then my youngest is 21. She was like the oops, you know. And my middle daughter was Miss America. Isn't that cool?
Oh, wow.
Isn't that crazy? That's like my claim to fame. Okay, I got it out now. I won't say any more about it, I swear. But if you want to Google her, it's Betty Cantrell, and you'll see her. All right, forget it. All right, the diaphragm, when positioned at rest, normal post-exhalation position, the dome. It's domed, and this dome position enhances what's called the zone of apposition. The ZOA, as defined by Troyer, is the area of the diaphragm encompassing the cylindrical portion of the diaphragm, which corresponds to the position directly opposed to the inner aspect of the lower rib cage. That was about as helpful as an alligator in a swimming pool. So what I really mean by that is the more domed the diaphragm is, that's the zone of apposition. That is the potential for inhalation. All right, having said that, any compromise to the position of the right or left hemidiaphragm or to bilateral leaflets of the diaphragm can result in dyspnea. A few signs of dyspnea. Ask yourself as you're looking at those few signs, have you had any patients describe to you any of these? We already know the answer. Yes. I have tons of patients. Do you guys have any patients with a scalloped tongue? Right? I mean, come on, Mike, really? You're asking that? Which posture is good? Say neither, because that's the answer. Neither posture is good.
What we look at is when we see traditionally with scalloped tongue is sleep apnea.
Yes.
But it's not daytime, it's the nighttime that caused that scalloped tongue. So what about daytime clenching and grinding, or more daytime clenching?
You want me to speak to that?
I think we're curious about that.
Okay, well, I'm going to eat it up
I mean, you guys
for
see
breakfast
people
here,
that clench
daytime.
right? And you tell them, stop clenching, and they don't. Some of you even do it. Why the heck do people clench daytime? We know they clench nighttime for airway compensation. We all know that by now. Why do they clench daytime?
Let's chat. It was like she was a plant in the audience for that question. Do what?
Interesting pattern, though. A lot of times when you really extract the history, the patients will initially be nighttime bruxers.
Mm-hmm.
And then over time...
They graduated to grad school.
Yes, and they usually, as they start getting some DJD in their TMJs, they're having some symptoms, and now they're doing daytime as well.
Yeah, they had to work hard to become a daytime bruxer. I spent all night working on this. Now I'm ready for daytime, baby. I'm ready for the major leagues. I'm graduated up to major league daytime bruxing. Watch me now. And we're going to talk about exactly why. So let's first have a quick anatomy class, because we're going to go to a place you haven't been. So everybody knows sternocleidomastoid, shake hands with him. He's an accessory muscle of respiration. Everybody knows scalenes, shake hands with them. By the way, SCM on the right is more dominant than SCM on the left. Scalenes on the right tend to fire a lot, but scalenes on the left are busier. If the scalenes on the right are busy, you have something called a superior T4 syndrome. There's a paper on that. Let's continue. Upper trap is an accessory respiratory muscle that's busier on the right side of most people than the left. Gosh, can you rub this knot out? It's right here. There's a reason for it. The upper trap is not only trying to assist with rib cage elevation, it's also trying to retract a scapula that is forward in this funky little position that I'm reproducing now. It'll never succeed in retracting the scapula because middle and lower traps take care of that. Upper trap doesn't even attach to the scapula. It attaches to the collarbone. All upper trap is good for is this or saying, I don't know. I use it all the time. I know for a fact. I'm good at I don't know. Upper trap, and then pec minor. So these are four major accessory muscles of respiration. Can you imagine that if pec minor is firing a lot, do you honestly think it's going to lift that rib cage or draw that scapula forward? It's going to draw the scapula forward before it ever lifts the rib cage. But it will try. Let's continue. There are secondary muscles that are secondary muscles of accessory respiration. the suprahyoid group and the infrahyoid group. And we know the omo, right? We know the omohyoid. The omohyoid attaches to where? Scapula. It's like, whoa, okay, now this gets interesting. When the omohyoid dives down here and then goes back and attaches to the coracoid process of the scapula, and I'm going to use that asymmetrically. I swore I wouldn't say asymmetric again, but I did it. An asymmetric omohyoid and an asymmetric rest of the supra and infrahyoid group creates massive distortions in bite. It also creates massive distortions in ability to bring one side of a tongue up versus the other. So just keep kind of going with me here. Let's continue. Now I've got tertiary muscles that are accessory. Palato, stylo, inferior, genio, and hyo. All of these are assisting in respiration. But how, Mike? But how? Well, we got to go to grad school, right? We got to get in daytime bruxism. So keep with me here. Let's keep going. So these muscles, the tertiary, the secondary, and then the accessories, all add up to a lot of muscle activity, but we have supporting actors. The supporting actors are designed to provide stability so that the accessories can do their accessory job. Think about these supporting actors. Let's dive in. Longus capitis. Longus capitis and longus colli are the abdominals of the anterior neck and reduce cervical lordosis. If they're firing too much, you've got posterior opposition that is lost, which means you no longer have a cervical curve in your neck. But let's continue. There's longus colli, I just mentioned them. And then obliquus capitis. I want you to look at the attachment site for obliquus capitis, and I want you to ponder what I'm about to say if you're a dentist. So you see that it's attached to the O and that it's attached to the A. Many dentists consider referring their patients to an OA chiropractor. I have no problem with that. But I want you to first consider that the greatest OA chiropractor in the world is a dentist. So, did you get the greatest OA chiropractor part? You got that part? I'm going to say it again just in case. But the greatest OA chiropractor in the world, pause for effect, is a dentist. That sounded better the second time, I thought. So, seriously, a dentist controls the OA joint better than anybody through either alteration in bite, which could be good or bad, through fabrication of a splint, which could be good or bad, or fabrication of, or ortho, which could be good or bad. The power that you guys wield, it's like a lightsaber. You control this joint better than anybody. You don't even need the saber. You can just go, we'll move the joint. Okay, let's move that joint. I can see nobody watched Star Wars. Let's continue. Rectus capitis posterior major. Notice the attachment. Let this guy spin around again. Notice the attachment. It's like our patients. Will you hold still? Another view. Temporalis. Masseter. Mike, I'm sorry, you have these listed as accessory respiratory muscles. Yeah, supporting actors, right? Let's continue. Medial pterygoid, and we could throw lateral in there as well if we like. So let's add them up. We've got 27 accessory muscles of respiration. 27 that are all saying, I'll help. Just let me know when you need me. And the patient's calling on them a lot, but there's a tug of war going on. There's a problem in this little paradise. And that's what, let's analyze the problem. We've kind of built the stage. Extension versus neutral. The mediastinum and breathing. So let's assume this person is in a neutral position. The ankle, neutral. Neither dorsiflex nor plantar flex. Knees slightly flexed. Pelvis at a 34-degree Ferguson angle. Hang on. Ferguson angle is this lumbosacral angle. So let's define that real quick. I'm going back. 30-degree lumbar lordosis. 20 to 40, so let's just say 30-degree thoracic curve. and a 30-degree cervical curve. We like 30. 30 is good. We need 30, 30, 30, 30. We got a lot of 30s. And OAs with 20 degrees available extension, 30 degrees total motion. Meaning, here's the atlas, here's the occiput. I have 20 degrees extension and 10 degrees flexion. 30 degrees total available motion. 30, 30, 30, 30, 30, and 30. That's normal. Assuming an extended posture. Now, this looks horrid, although we see patients like this. I want to go through this. Plantar flexion of feet. That means the ball of the foot is pushing down into the floor. You might ask your patient who bruxes, how often, do you have any foot pain, like plantar fasciitis? There's about a 50-50 shot the answer is going to be yes. Maybe greater. I'm spitballing. But a high likelihood that there's foot pain. Or they'll say, well, I don't have plantar fasciitis, but you know my doc, he diagnosed me with something in the front of my foot. Morton's neuroma? Yeah, that's it. Stress fracture of your second metatarsal head? How'd you know? Because you're spending an inordinate amount of time on the balls of your feet, pressing them down into the floor. You can almost feel that with your hand if you take your hand and you do this. So I'm taking my shin bone forward and my knuckles are driving into this desktop. And it kindly hurts. That's how we say it in Georgia. You know, we're still marrying our cousins there. I just need you to know that right out of the gate. I'm not from Alabama. They're dating their sisters. I saw one. All right, so anyway. Who said that? Who said roll tide? Don't you even go there. All right. Go Braves. All right, so anyway. Extension of the knees, meaning the knees are too far that way. That way. Forward rotation of the pelvis. Now that Ferguson angle is getting too steep, which means my pelvic outlet is behind me. You know there's a huge correlation between pelvic floor dysfunction and TMJ. Wow. Wonder why? Well, we're talking about that, aren't we? Deeper lumbar lordosis, reduction in T-spine kyphosis, or heightened T-spine kyphosis, depending on how the patient compensates. Depending on whether or not they've got a pectus excavatum. Depending on whether or not they have bilateral flaring ribs. There's a lot of variables. The higher up you go, the more complex it gets. Well, that's kind of scary, dentists, because we're headed up to complex city. I mean, down here it's a flip phone. But up here, it's my MacBook that I still don't know how to work. So, forward head posture or military neck. Anatomically, here we go again. Here's the atlas. Here's the base of my skull. In a forward head posture, you have A on O extension. And in a military neck, you have A on O extension. We need flexion for a curve. So keep it in mind, either one is compromised airway, but wait, we're still rolling. And OA or AO, extension, there it is. This sets the stage for accessory muscle groups to become overactive. But how? Let's go. So first understand this thing called the rib cage. You have an anterior, a middle, and a posterior mediastinum in the inferior section. It's also up here as well. So in the apical region of the chest, you need to be able to breathe. In the anterior portion of the chest, you need to be able to breathe. And in the back, you need to be able to breathe. By the way, you see this yellow stripe right here? That's called the sympathetic trunk. When you have a flat mid-back, you have pressure of your rib cage against the sympathetic trunk, which heightens anxiety and heightens the sympathetic nervous system. Good posture is bad. It creates anxiety. Doesn't it also create a hyperinflation state, which is also by itself anxiety producing? Wow, let's keep going. I have to be able to expand in all of these areas. Which area, by your own reckoning, no schooling on this, which area do you think expands the most? I'll give you a hint. We're all good at belly. We rock the belly. Which ribs are most cartilaginous? Ribs 8, 9, and 10. they can turn out like a boss. Which ribs don't rotate well? All the rest. So where am I going to expand the most? Down here. Second place, right here. Third place, out here. Fourth place, back here. But they all should be able to expand. And if I'm hyper-erect, do you think I'm going to expand my posterior mediastinum? Hell to the no. Let's keep going. Oh, what did I write? During full mediastinal expansion, the chest wall should be able to expand forward, blah, 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 blah. Accessory muscles can aid in this oh, this is important. Accessory muscles can aid in this expansion, but primarily act to lift the chest wall. That's fine, but you can't do it for long. Now think about it. They primarily act to assist. Where are they located? Where do they attach? What do you think they can do? Lift. That's all they got, including my traps. When the human lifts the chest wall with accessory muscles, a great deal of stabilization must occur with the muscles listed as pharyngio-glossal and supporting actors. Overuse of the accessories can result in a cascade of events that can become problematic. Additionally, this extension patterning is facilitated with major groups like lumbar and thoracic paraspinals, the psoas, and even the gastrocs. Let me demo. I'm going to take a breath by pressing the balls of my feet into the ground and lifting my rib cage with my calves. You know, I've got a problem. My right calf is bigger than my left. Pay attention, and you'll see that on most of your patients. If the left is bigger than the right, pathology. But I digress. If you have patients who have repeated and recurrent Achilles tendonitis, all you have to do is ask. You have any problems with your calves? Calf strains, Achilles tendonitis, cramps, and all that kind of stuff? Why, yes, as a matter of fact, I do. Huh? Foot pain too? Yes, that ball of the foot thing that I told you that my doc said was Morton's neuroma. Yeah, that's it. Because they're all one and the same. I'm lifting my rib cage with my plantar flexors, my calf, gastroc soleus muscle group. Let me keep going. What you're looking at is taken from a write-up about emphysema, COPD. So my question, is this good posture? Well, if we put this in a posture book where they teach about how to stand up straight and put the book on your head, they'd say that's great posture. I'm telling you that is chronic hyperinflation with a loss of a ZOA, zone of apposition, dome to the diaphragm. This person must use his accessory muscles of respiration in order to assist lifting of his rib cage. Like the COPD patient, the patient without COPD who overuses accessory groups is attempting to maximize airflow. It's a paradox through engagement of the accessory groups. Forward head posture, its structural and functional influence on the stomatognathous system. A conceptual study from the Journal of Craniomandibular Practice, way back. The upward vectors of pull on the chest by the accessories creates a downward vector of pull on the mandible. You hear what I said? Now we're getting where the rubber meets the road. I'm pulling my chest up with what? Stuff that attaches to this thing. I have to use this thing as a support structure now. How can I do that? You already know the answer. Let's keep going. Increased activity of the accessories, especially the supporting actors known as temporalis and masseters, with subsequent mandibular depression, forces now in play results in increasing activity of the mandibular elevators. These would be the masseters and temporalis. I can't lift my chest without a solid anchor. So what am I going to do? Brux in the daytime. Clinch, lift. All day long. We probably could have just said, hello, my name's Mike Cantrell. Patients clench their teeth so they can lift their chest. Have a nice day. Do what? What'd you say?
I said, do you want to show everybody, Angela, you're the rap?
So, as the masseters and temporalis muscles activate, the need for occlusal support increases and the bite closes toward maximal intercuspation for neurologic referencing and stabilization. Whoa, neuroreferencing and stabilization. This activity reinforces security for the neck and head as the upward forces on the chest increase simultaneously with the anterior neck activity. That's a mouthful. Let's just pause there for a minute. Mota said from Brazil, temporomandibular dysfunction in cervical spine and occlusion in adolescence, and cervical posture. Correa, temporomandibular disorder and dysfunctional breathing. Gomez, a possible attenuation of stress-induced increase in striatal dopamine metabolism by the expression of non-functional masticatory activity in the rat. Basically saying, rats clench too, even when they're not eating. Simultaneously, this is where it gets interesting, there is also a downward vector of pull on the tongue as the struggle to raise the anterior chest wall continues. Let me lift that chest wall. Downward pull on the tongue, hyoids. Excessive anterior cervical muscle tone affects hyoid bone kinetics during swallowing. Excessive anterior cervical muscle tone. Remember the supporting actors like longus colli? Anterior cervical muscle tone. Flattens the curve. The tongue can be drawn downward and lie within the mandibular arch rather than maxillary arch. The low-lying posture of the tongue creates yet another cascade of issues that we'll talk about later because that's a whole nightmare. I can hand the clicker now. You guys could do that talk any day of the week. It is effectively unable to rest in the normal position, which is at the roof of the mouth, behind the front teeth and against the incisive papilla and the lateral ridges. So dentists could look at this mouth. We could look at this face and see multiple signs of airway dysfunction. I had this slide up in another talk, so I'm kind of digging on it right now. So sign number 1, holler it out. What do you see? Nostril. Sign number 2.
Midline discrepancy.
Ooh, that's sign number bonus. Midline discrepancy, rock the house. We're going to get into that. Next one, sign number 3. That was 2A. Deep palatal vault, and that kind of correlates with the midline discrepancy. Keep going. Sign number 4. I don't know what that was. Prominent rugae. Say prominent rugae.
Prominent rugae.
Nice. Sign number 5. Dentist, come on, don't let me down.
Worn posterior teeth.
Worn posterior teeth, but bigger than that. 2 teeth are amputated. You see them? Isn't he missing some teeth? So if he had a tooth amputation, you like the word I chose? Tooth amputation, because it's a limb. Teeth are proprioceptors for the ground. This guy had 2 legs taken away from him. So when you amputate teeth, you collapse the airway. You collapse the premaxilla. It falls inward. Remember Liao's book? The 6-foot tiger in the 3-foot cage? Boom, in your face. He said, you can't do that. That's against the law. When you bring a midface in, you're collapsing the airway. So he's missing teeth. We got to love the midline shift because we know he's got a scoliosis and he's pronating on his left foot. But we know this is compensatory because he's internally rotated on the right side of his palate and externally rotated on the left. Do you see that? This is a sidebar discussion that has nothing to do with our talk. But it's worth hearing. This midline shift to the right is compensatory. That is a torsion patient. So we know he's got an airway compromise. But I digress. His tongue's not spending any time up there because of the prominent rugae, or their evidence. The prominent rugae is evidence that his tongue is not keeping his rugae from being prominent. Right? If the tongue was up there, these rugae wouldn't be so big. They'd be smooth-a instead of rugae. There's a strong tendency for the tongue to then splint or press against the bottom teeth. Remember the eagle syndrome that we were talking about earlier? This is that lady. This is the lady. Okay. She's the one with the entirely calcified stylohyoid muscle on both sides. She's whacked, let me just tell you. She was in a wrestling match with her husband. And I was like, come on. Wrestling? She goes, no, I swear to you. I was like, come on. And she goes, okay. And I was like, I knew it. So they were getting kind of rowdy, in the bedroom. Anyway, and she strained her back.
Well, look what I was
And so when she strained her back, we started realizing she had multiple problems all the way up the kinetic chain, including right in that maw right there. Look at that. That is a nice example of some scalloped tongue, right? So we know she's low-lying with that tongue, or at least splinting it against the top and bottom teeth. It can be significant enough to create the scalloped appearance that you guys are all so familiar with, because they take on the shape of the teeth. But this lady also has stylohyoid muscles bilaterally that are completely calcified from the attachment site to the attachment site. She grew a new bone. She doesn't have a stylohyoid muscle, she has a stylohyoid bone. Wow, bilaterally. That's a busy neck. The splinting posture of the tongue, coupled with the proprioceptive splinting posture of the bruxing teeth, can create a feed-forward mechanism for extension patterning that perpetuates the neck-based respiration and subsequent raising of the chest. Wait a minute, Mike, are you saying that this tail can now wag the dog? Oh yeah. It started out as an innocent nighttime bruxer whose dog was just wagging his tail, and then eventually the tail got such a big play that it's now wagging the dog. Who's going to disrupt that pattern? Well, say it again. Yeah, we'll start with a dentist, but you know, it wouldn't be fair. It just wouldn't be fair. No, but I'm down with that. I'm like, let's blame it on the dentist. I'm all for it. Damn, dentist, you guys suck. No, honestly, we're all playing a role in this because we're now aware. So you can't unsee this, right? We can't unsee it. It's now out there. It's in the ether. The bell has rung. The smoke is out. The genie's out of the bottle. So everybody in here now knows this. In other words, what began as ribcage body extension for enhancement of respiration becomes bruxism and tongue stabilizing activity for paradoxical assistance in respiration that drives the exact extension of the ribcage. I'm now wagging the dog. Questions? It's like, can you shut up? That would be a great question. So if you have questions, I'll entertain them. If you don't and you want to bail, I totally understand. I mean, I wouldn't want to listen to me for that long either. I'm down. All right. Thank you so much, y'all. I really, really appreciate the opportunity to have a chance to talk to you. There's a ton of material related to this. This is literally the tip of a huge iceberg, because everything that I just said to you here occurs non-symmetrically. That complicates it a lot, like a lot.
I kind of wanted to add a few things about the whole tongue thing because this happened to me a lot until I met Mike. You know, some of you guys have people with anterior tongue tie and you send them to a myofunctional therapist and they do a great job exercising that tongue. Then you get them to go see Rachel or Laura or anybody who, or yourself who, you know, do a little release on the tongue. And then you get relapse. I know you guys have seen relapse, right? The reason is because they're still trying to use that tongue to lift that rib cage so they can breathe. So that's the reason why when you're doing that, you have to look at the respiration. Because if you don't look at the respiration, you'll be successful one way, but you may not be fully successful long term. It's that relapse that I keep seeing in my practice for so many facets that I see. And I realize it's because I'm not looking at the body. One other thing, you guys have patients that, I know if you guys are working in tongues, you've seen this. If you clip that tongue and release it, the patient freaks out. They can't walk, they can't find their feet. They freak out and they're mad as hell about it. The reason is because they're using that tongue to stabilize their feet and breathe, and now you clip their ability to do it. And you didn't teach them how to handle their body when you do it. Okay, so that's why I became passionate at this, because I feel like we finally have a solution.
You're passing out.
And
When the patients come back and tell you, you thought you did a great job taking care of them, but why are they out of balance? You know, I'm seeing nods from people who really work with them that are, especially children, right? You clip that tongue, all of a sudden they can't find their way in space. It's because they don't know how to breathe with a tongue clip, because all their lives they breathe with their tongue tied. You've literally crippled them from being able to breathe. They're having panic attacks.
Well, you're robbing them of grounding sense.
Right.
So you rob when you clip the tongue. 'Cause, I mean, there's nothing wrong with clipping a tongue. Of course, there's great applications for releasing a tongue tie. But when you release the tongue tie, be aware that that may be their reference, neurologically speaking, for grounding sense. So you know, with great clipping comes great responsibility. So we just need to be aware.
Right, but how do you teach them to compensate?
You teach them to not compensate.
The postural therapist.
That's what you do. You give them a new reference. This is actually a good question. So the question.
We have a PT in the room. Well, no, you answer that first.
We'll work with, answer that.
Answer this question? Shannon. Hang on. So Shannon is like, okay, so how do you give them, I'm going to rephrase it, you tell me if I ask it right. How do you give them grounding sense, right?
Or to compensate.
How do you teach them to not compensate, correct? Right. So if you're going to clip that tongue and you're robbing them of their grounding sense, I'm committing this great sin, right? So obviously then we want to make sure that the sin is not committed by then replacing this reference that they're using with a correct reference. That's what I'm suggesting is it takes a little bit of time to kind of learn that. But if you give them things to feel your heels, feel your rib cage descend, feel expansion of air into your back. Right now what we say, we'll clip the tongue and say, make sure you keep it up, which is great. But while you're keeping it up, if you're on the balls of your feet, you'll never succeed. Never. I promise you, you will not. If you were to go back and look at the people who've had issues with their tongue release, check and see where their center of mass is. You're going to see they're forward every time. Not, I think, maybe, possibly, every time. Get them on their heels. When you're teaching them to sit, when you watch them sit, you're going to notice they sit hyper erect. Teach them to slouch. Teach them to feel their two sit bones. Find and feel your sit bones under you against the surface upon which you're sitting. Feel your heels. Feel your sit bones. That's a great start. Many times that's all you need. Many times you need more. But I mean, if you have someone like that, we just holler, just shoot up a signal flare, call Alice, call James, call me, call somebody. Yes, ma'am.
What about the stabilizers, like working on the neck stabilizers, the intrinsic muscles?
So what we have to think, she's like, what about the neck stabilizers, the intrinsics of the neck? So if you think about, like if this is a neck facing this way, here's a normal curve in that neck. The more the anterior portion of the neck is active, what we realize immediately is that we're lacking posterior neck muscle activity. So we need increased posterior neck muscle activity. All they have in the posterior neck is suboccipital muscle. That's it. And when suboccipital muscle fires too much, it's headache city, right? Oh, I hurt right here. So increasing posterior neck muscle activity is what you want to recreate the curve. But guys, posterior neck muscle activity can't activate with a rib cage that's in a state of inhalation. When you drop rib cages down, you put a curve in a neck. The worst thing in the world we can do is teach a patient chin tucks. This is not good. Chin tucks are bad. Pretend there's a string here pulling you up. Put the string around your neck and hang yourself, it would be better. So just don't do that. Rib cages drop. And rib cages drop depending on the leg upon which I'm standing. So teach a patient to exhale. It's easy. They're laying on a table, we're PTs. They're laying on a table. Mr. Smith, how you doing? There's his head, there's his feet. Put your hand on his left rib cage and guide his rib cage down. Take a few breaths. The results can be stunning. You'll immediately create a curve in his neck. Like in seconds, not in 3 weeks, in seconds. And there's objective tests that can tell you how well you did. There's his subjective feedback. But the objective tests can belie that feedback or validate it. There's a lot to do. But don't do chin tucks. I'm down. I saw your expressions earlier. I was like, she's so down with this. Read the audience.
Interested in a little bit more in depth, where we're basically going to take you with the knowledge you have now and build on it to something meaningful in your practice. Elizabeth Cahey, Mike Cantrell, James Anderson, and Heidi Weiss, who is the neuro-optometrist in charge of Pure Eye Vision. They're going to be here Thursday evening, January 27th, and all day Friday, January 28th. And if you guys text me or email or text Mike or email Mike, we'll get your names, and when it comes, we will definitely, I got the roster here too, we'll let you guys all know, and we're gonna do a course, and it's gonna be a very meaningful course, because you'll leave that course changing your exam just a little bit, where you're gonna be considering the posture in your examination. And really be able to collaborate with each other, because when you start doing that, you're going to see collaboration. I need to be able to reach. The ultimate thing is your patients.
Baby, hell yes.
Really appreciate you, and you're going to absolutely be a different type of dentist, because no dentist has ever looked at how they breathe. And I'll tell you, when I started doing this, my patients didn't say, "This is weird, you're doing this." They're like, "My doctors don't do this. Even my physical therapists, I'm sorry, don't do this. You guys are the first," and I've always known I had a breathing problem. I didn't know who to tell it to, and I didn't know, I just knew something was wrong. And you know, I can't breathe very well. I don't feel I can inhale very well. You'll hear that all the time. They never say they can't exhale very well. So they'll say they can't
Never.
inhale. So guess what they try to do? They try to take classes that teach them to inhale more. But what did Mike say? It's about the exhale. And so even my dental assistant, my front office, everybody knows how to teach our patients how to exhale. It's a big deal. Because when you teach someone to properly exhale, it creates space for great inhalation. So we're going to talk about that in the January meeting. So we'd love to.